Good morning, students. Today's class we will see about the obstetrical labor. The definition is obstetrical labor is one where, in spite of good uterine contractions, the progressive descent of the presenting part is arrested due to mechanical obstruction. This may result either due to factors in the fetus, that is the passenger, or in the birth canal, that is the passage, or both, so that further progress is almost impossible without assistance. Causes: fault in the passage include bony. The cephalopelvic disproportion and the contracted pelvis are common causes. Secondary contracted pelvis may be encountered in multiparous women. Soft tissue obstruction. This includes cervical distortion due to prolapse or previous operative scarring, cervical or broad ligament, fibroid, impacted ovarian tumor, or non-gravid horn of the bicornuate uterus below the presenting part. Fault in the passenger, that is transverse lie, bra presentations, congenital malformation of the fetus like hydrocephalus is the most common, fetal ascites and double monsters, big baby, occipitoposterior, compound presentations, locked twins. Morbid anatomical changes in the uterus include morbid anatomic changes in the response to obstruction have already been described in relation with the formation of pathological ring or the Bandel's ring in the previous video we have already discussed. Means we will just continue. The lower segment elongate and becomes progressively thinner to accommodate the fetus driven from the upper segment. A circular groove encircling the uterus is formed between the active upper segment and the distended lower segment called pathological retraction ring at the Bandel's ring. Due to pronounced retraction, there is a fetal jeopardy or even the death of the fetus occurs. The anatomical changes occurs in the bladder include bladder become an abdominal organ, and due to compression of the urethra between the presenting part and symphysis pubis, the patient fails to empty the bladder. Transverse depression at the junction of the superior border of the bladder and the distended lower segment is often confused with the Bandel's ring. The bladder walls get traumatized, which may be lead to either blood-stained urine, common finding in the obstetrical labor. The base of the bladder and urethra, which are nipped in between the presenting part and symphysis pubis, may undergo pressure necrosis. The devitalized tissue becomes infected and later on may slug off, resulting in the development of genitourinary fistula. The effects on the mother. Immediate effects are exhaustion is due to constant agonizing pain and anxiety. Dehydration is due to increased muscular activity without adequate fluid intake. Metabolic acidosis is due to accumulation of lactic acid and ketones. General sepsis is invariable accompaniment, especially after the rupture of membranes with repeated vaginal examination or attempted manipulated outside. Injury to genital tract includes rupture of the uterus, which may be spontaneous in multipara or may be traumatic following instrumental delivery. Postpartum hemorrhage and shock may be due to isolated or combined effect of atonic uterus or genital tract trauma. All these lead to increased maternal morbidity and mortality. The deaths are due to rupture of uterus, shock, and sepsis with metabolic changes. Remote complications include, even if the patient survives, the following legacies may left behind, like genitourinary fistula or rectovaginal fistula, variable degree of vaginal atresia, secondary amenorrhea following hysterectomy or due to rupture or due to Sheehan syndrome. Effect on the fetus. Asphyxia results from tonic uterine contraction that interferes with the uteroplacental circulation or due to cord prolapse, especially in the shoulder presentation. Acidosis due to fetal hypoxia and maternal acidosis. Intracranial hemorrhages is due to supermolding of the head leading to tentorial tear or due to traumatic delivery. Infection, all these lead to increased perinatal loss. Clinical features: patient with agony with continuous pain, features of exhaustion and ketoacidosis, abdominal palpation reveals upper segment distended and tender, pathological ring placed obliquely between umbilicus and symphysis pubis and rise during the course of time. Fetal parts may not be well defined, FHS usually absent. Internal examination reveals vagina dry with hot with discharge of NC, cervix is fully dilated, membranes are absent, cause of obstetrical labor is relief. Prevention: antenatal detection of factors likely to produce prolonged labor like big baby, small woman, malpresentation position, intranatal continuous vigilance, use of autograph, and timely intervention of prolonged labor due to mechanical factors can be prevent obstetrical labor. Failure of progress of labor in spite of good uterine contraction for a reasonable period at least 2 to 4 hours is an impending sign of obstructed labor. Actual treatment. The underlying principles are to relieve the obstruction at the earliest by safe delivery procedure, to combat dehydration ketosis, to control sepsis. Preliminaries, fluid electrolyte balance and correction of the dehydration and ketosis are done by rapid infusion of glucose solution. At least 1 liter is to be given running trip. At least 3 liters of fluid is required to correct clinical dehydration. A vaginal swab is taken and sent for culture and sensitivity test. Blood sample is sent for grouping and cross-matching, and bottle of blood should be handed prior to any operative intervention. Antibiotics should be given. IV infusion metronidazole is given for anaerobic infection. Static management. Before proceeding to definitive operative treatment, rupture of uterus must be excluded. A balanced decision should be taken about best method for relieving the obstruction with the least hazards to the mother. The frantic attempt to deliver a morbid baby by method of ignoring the risk involved to the mother is indeed in bad obstetrics. There is no place of weight and waste, neither any scope of using oxytocin to stimulate uterine contraction. Vaginal delivery, the baby is invariably dead in most of neglected cases, and destructive operation is best choice to relieve the obstruction. If, however, the head is lowered down and vaginal delivery is not risky, forceps extraction may be done in a living baby. There is no place of internal version in obstetrical labor. After completion of the delivery, expulsion of placenta, exploration of the uterus and lower genital tract should be done to exclude uterine rupture or tear. Cesarean section. In case detected early with a good fetal condition, cesarean section gives the best result. But late in neglected cases, even if the fetal heart sound is audible, desperate attempt to do a cesarean section to save unmorbid baby more often leads to a disastrous consequence. Not infrequently, babies either delivered stillborn or dies due to neonatal sepsis. The postoperative period of the mother also becomes stormy, at times ends fatally. Symphysotomy. The place of symphysotomy has to be duly considered in the developing countries as an alternative risk is cesarean section. Can be done in the case of established obstruction due to outlet contraction with the vertex presentation having a good FHS. Thank you.